Welcome to Eye Contact. I'm Sean Henahan. What does the cataract surgeon need to know about glaucoma today? Today we're asking Dr. Roberto Bellucci that question. How do you proceed, first of all, in a question of early disease?
In early disease means topical therapy to lower the IOP. So we have a protocol that includes visual field examination, optic nerve head examination, and all what's required pachymetry in order to assess the diagnosis and to precise the target pressure. Then we fix the target pressure and try to go to the target pressure by lowering IOP with topical drugs, basically. I start with beta blockers. I don't like prostaglandins because of the pro-inflammatory effect they have. Of course, if required, they must be used. Maybe sometimes we go with laser treatment, the argon laser trabeculoplasty or selective laser trabeculoplasty, and that's all. I try to keep it as smooth as possible on patients.
And if that patient looks like he's going to need cataract surgery, are you less concerned than a person with more advanced disease? Are you more likely to operate on that patient with the mild glaucoma compared to more advanced disease?
In case of a cataract, I encourage the patient to receive an early surgery. At ECRS meetings, we learned that every type of glaucoma surgery will provide better results if performed together with a cataract operation. On top of that, we know that cataract surgery alone will decrease intraocular pressure for a while, not forever, but for about 2 to 4 millimeters of mercury, so it's welcome.
So you can now factor that in. You're thinking, okay, I'm going to do phaco, I'm going to get this benefit.
Sure. Not adding any glaucoma surgery, or I should say filtration surgery at the beginning. You may select to apply some form of mix or to improve the aqueous outflow, the aqueous facility, but not the true filtration surgery at the beginning if it's not needed by an advanced glaucoma stage.
And what about the follow-up in the patient with mild glaucoma that you have done a cataract procedure? Are there special considerations there?
Even if the IOP peaks immediately after surgery are not considered dangerous as usually, I try and avoid them. And later on, I tell patients, you can now remove your glaucoma drugs or decrease them. But remember, this will be temporary, just to encourage them to come to follow-up visits, not thinking the glaucoma has been solved.
And how long would that follow-up go on?
Forever.
But how long would you expect
Yes, but because what I do is to defer visits, increasing the interval between two visits, if the IOP is very low. So maybe I can tell them every 4 months for the first year, twice a year for the second and third year, and then yearly.
So do you see an effect lasting for 3 years sometimes?
Yes. Yes, because maybe at cataract surgery, the trabecular meshwork was cleaned up, has been cleaned up, washed by the IA connected with cataract surgery. This has been published, especially for pseudoexfoliation, providing a substantial and lasting improvement in IOP.
So cataract surgery in glaucoma patients is usually recommended to be conservative. Is there a place for multifocal IOLs?
Very little room for multifocal IOLs, very small place, because those lenses require a perfect eye to work. And this is not the case of most of our glaucoma patients. Then a number of secondary procedures is often required. And our glaucoma patients won't accept a LASIK that might damage the ocular surface in those delicate eyes that had received a lot of drugs. And then most of glaucoma patients are in older age. They are not really interested in spectacle removal.
So would you ever consider using a presbyopic lens of some kind in a glaucoma patient?
Only in early cataract surgery performed for angle closure glaucoma. Those patients are in their 50s and hyperopic, and they like having multifocal lens, and we know that cataract surgery will probably solve that glaucoma completely. So in those cases, yes, I recommend multifocal lenses.
Now, what about a patient who has undergone previous corneal refractive surgery, has glaucoma, and now has a cataract? How do you proceed there?
In that case, I go with my regular cataract surgery and monofocal lenses. Let's say no exception. Monofocal lens. Those patients are unlucky. They cannot aim at spectacle independence on top of the several problems they had. Usually those patients were myopic. And we know that myopic retinal conditions, even when there is no retinal attachment, probably will impede the exploitation of a multifocal lens. So there is no reason.
So it would really be the same as any patient who has had previous corneal refractive surgery who now requires cataract surgery?
No, because in those cases when there is no glaucoma and the retina is perfect, if the cornea has a reasonably large optical zone and we can rely on recent IOL power calculation formulas, I can implant a multifocal, I do,
right.
But not in the case of glaucoma.
Well, thank you for describing these very difficult cases. And thank you for joining us. For more information, please visit us at eurotimes.org.